Hello, my name is Julian Johnson. I am a Claremont School of Theology Doctor of Ministry student, and thank you so much for attending this webinar. Today, I'd like to present with you pastors as caring bridge builders in healthcare settings. And one of the goals of this seminar today is to be able to share with you effective ways and means on how to be more effective in your ministry. One of the goals of today's broadcast is to be able to share with you some more effective methods that I know that you probably already use, but more effective methods in your ministry to service those around you. I would like to tell you just a little bit about myself. I am a pastor and I have served as a pastor in the South Central Conference for a number of years and want to share with you the goal of this seminar, which is to equip pastors with strategies to assist in end of life and crisis care situations. I've served as a pastor in the South Central Conference for 13 years. I pastored in rural, urban, and suburban contexts and settings. I pastored one, two, and three church districts in Alabama, Florida, and Mississippi. Currently, I'm a staff chaplain in cardiology at Florida Hospital in Orlando. So, I'd like to share with you a few functions of pastoral care. One of the main functions of pastoral care of the four is sustaining, that is, giving support, comfort, understanding to help a person through a time of crisis, whether small or great, short lived or ongoing. Number two is guiding, helping a person either by direction, clarification, or confrontation to find solutions to life's problems or hardest questions. Healing is aiding a person to find from wholeness, wellness or wholeness from brokenness, injury, and or disease. In pastoral care, we usually mean brokenness, injury, or disease in a spiritual and or an emotional sense. This will come up more to play as we go forward. So finally, reconciling is helping a person to restore a relationship that has been broken either with a person, a group of people, or God. I'd like to share with you my story and my introduction to crisis care. In my first pastoral assignment, I was called to a family whose child was paralyzed as a result of a major accident. One Sabbath after church, I was given the grim task to assist the family in understanding the conversation with the physicians. I had the sad task of sharing with the family that the daughter would never walk again. What can be said of my experience was the fact that I'd been a seminary graduate. In undergrad, as a theology student, I had been told that pastoral visitation was a primary function of the pastor. What I realized post that crisis in my first district, I had been trained to preach, educate, and administer the sacraments, but I had never been trained to visit people or respond effectively in crisis. That's what I seek to share with you today. I had been trained to socially visit people. Once I had my clinical pastoral education training, CPE training, I realized I missed so many opportunities to grow deeper with my congregants. I was trained as a theologian and preacher, and according to General Conference Education Department core curriculum, for theology students, they only require two classes related to nurture, pastoral care and counseling, and marriage and the family. Other classes related to nurture are electives. It was not until my first unit of CPE that I realized that my perspective on ministry was one sided. I was focused on discipleship and evangelism and less on healing and reconciliation. Pastoral care principles provide opportunities for healing and restoration of families and congregation. So I'd like to share with you a few skills that can be translated from clinical setting to parish. Uh, Clinical setting, hospital or institutional setting to the parish. There are many skills that are transferable to the parish, which include presence, visitation, assessment, and active listening. First, the ministry of presence. The words I've come to be with you can help provide comfort during your ministry of presence. This ministry may be a difficult one for some. Presence also includes silence, which may include lengthy periods without words. In short, being present includes being mentally engaged and willing to minister to a need. The first goal of crisis care in hospitals or in crisis settings, to expand the conversation, is to communicate a willingness to share the experience. Something as simple as saying, I have come to be with you, is powerful. This statement evokes presence, meaning, and trust. Too often, pastors are too wordy and sometimes too uncomfortable with silence. Visitation is a time to connect with those you are serving. Visitation is also an opportunity to be able to listen to different needs. Two types of visits will be discussed on the next slide: social visits and pastoral visits. There are many other types of visits, but we'll delimit our conversation to these two. Social visits have time parameters, primarily surface conversation, a sprint. They allow for a flow of topic, is led by the listener, and social visits are usually based on the context. Pastoral visits, on the other hand, are open ended, move to deeper levels. They are a journey and maybe the only time you get to experience the real side of a person. Pastoral visits use assessments and also they are led by the care provider. So, visitation in crisis. Kubler-Ross, the book on death and dying, the 1969 classic book. Kubler-Ross originally applied these stages to people suffering from terminal illness. Later, any form of catastrophic or personal loss was included, which includes loss of job, income, or freedom. This may include life events such as the death of a loved one, divorce, drug addiction, the onset of a disease or chronic illness, infertility, a diagnosis of infertility, as well as many other tragedies and disasters. The five stages of death and dying are these: denial and isolation. This cannot be happening to me. How dare this happen to me, says the angry person. Number three, the third step is bargaining. Just let me live to see my son graduate or to fulfill some kind of desire that you've always wanted to do. Depression. Number four, I cannot bear to face going through this, putting my family through this. And then acceptance. I'm ready. I don't want to struggle anymore. All of these stages of death and dying do not necessarily happen in sequential order. They can come up at any time, at any moment. Based on the fact that you have all these stages and the crisis happening, I would suggest debriefing sessions may be an effective way to allow for communal grieving. These sessions may occur in place of a Wednesday night prayer meeting, at the repast of a funeral, at the home of the deceased, on Sabbath following the worship service. Dual goal is to allow people to talk and to get comfort from one another. Many times in death situations, there are many family members and loved ones and friends who would love to say something during the official funeral or memorial service, but are not able to, either because of time constraints or because they are not able to speak from an emotional perspective. I would suggest also that during this time of visitation, time of debriefing, it's possible that some assumptions from a pastor perspective may occur. One assumption may be that a longtime member, case in point, may be spiritually strong enough to deal with the loss of a child or grandchild. What is useful in learning about someone's experience is asking the question, what is this experience like for you? The words for you offer an invitation for the other person to speak and to share their experience. Now, I'd like to share with you about advanced directives. These advanced directives, along with other life planning tools such as wills and trusts and things like that, do not evoke death as soon as they are signed. However, they may evoke confidence in family members and friends. There are some statistics about advanced directives. Only about 30% of all people in America have an advanced directive. In La Crosse, Wisconsin, it is different. 96% of people in that city have an advanced directive, according to a National Public Radio survey recently. The difference is in education. People were prepared. Now, advanced directives are documents by which a person makes provisions for healthcare decisions in the event that in the future he or she becomes unable to make those decisions. There are two types of advanced directives: the durable power of healthcare attorney and the living will. I cannot underestimate the meaning and the value of advanced directives more. If there was a stronger way to say it, I would almost say everyone must have it, but to say that would be too strong. I would strongly suggest everyone have one. If you're an administrator, it's wonderful, be wonderful to use your influence to have all those under your care, from janitor to your second in command, to have an advanced directive. It assists everyone to have peace in the midst of uh, disquietude as a result of death. Advanced directives in a durable power of attorney for healthcare: a person designates a trusted family member or friend to make healthcare decisions for you if you are unable, either temporarily or permanently, to do so for yourself. Most people think such a document is only for those who are very sick or very old. That's not true. It's absolutely essential for anyone who is 18 years or older. Advanced directive decisions include placing on life support, removal from life support, having a do not resuscitate order, or having a limited DNR only to ventilation, to allow natural death, or to participate in organ donation. These are just a few of some of the major advanced directive decisions. So if someone says to you, pastor, chaplain, elder, preacher, would you assist me? I'm wondering about making this decision. If only 30% of people in an advanced care directive have an advanced directive, that means only 31 in 3 of the people you are serving, you are leading, you're preaching to, you are shepherding, have advanced directives. Now, too often, advanced directive and advanced care planning also includes funeral planning. And and I'm not sure about you, but I have had emergency board meetings and other types of meetings to help to put together monies to help to bury a person. And I believe with a proper planning, everything can be taken care of. Most declarations on a living will instruct an attending physician to withhold or withdraw medical interventions from its signer if he or she is in a terminal condition and is unable to make decisions about medical treatment. This is usually done by physicians who have little or no connection to you, your patient, or family member. The living will is signed by you, but the physicians are carrying out their wishes in case there is no signer. Assessments. In the midst of all this chaos, there's still some care, some ministry that can take place. Spiritual assessments provide useful guidance for the pastor and chaplain to use to direct care. Some people may find doing spiritual assessments difficult because assessments require confrontation. Confrontation isn't a negative thing. In Mark 8:29, Jesus says, "Who do you say that I am?" That's a very direct question that Jesus asked his disciples. Assessments seek to identify significant relationships, identify meaning and purpose for the person, and they also seek to assist a person in applying meaning and or a person's beliefs to a medical condition or situation in life. Spiritual assessments assist in helping a person to authentically share emotions and feelings associated with a life event, diagnosis, or life change. There are several assessments, but I like to use the assessment SMC that I learned during my residency from a colleague of mine. As both chaplain, and pastor, I do not assume that a person is spiritual just because they attend church. So the assessment SMC goes for S, spirituality and support. So you ask the question, where are you in this situation? Where do you see God at work in this experience? What support do you have? How has that support been for you? What do you have access to the resources needed to meet your present or long-term health challenge? Through these questions, you might just get through one. There's some people who you think have support that may not have support. Some people you think are spiritual are not spiritual. From the perspective of meaning, you ask a person, what is it like for you to lose your hair? Do you know what it's like to lose your hair? You may be bald. You may have hair other and you may have missing hair, but you don't know what it's like for that person who you're talking to who has lost their hair. What does it mean for you not to have the support of your family? What do you feel when you think of your loved one? And then finally, coping. What is helping you to cope today? And are you angry with God? Healthcare interventions in the midst of all this are helpful for you to understand as a pastor, clergy person, minister, administrative, teacher, whatever your ministry capacity that you're viewing this webinar. Healthcare interventions are, and these are just a few: breathing machines, counseling, food, therapy, as far as psychiatric therapy or the psychologist type of therapy, physical therapy, occupational therapy, prescription drugs, and most of all, a lot of pastors come in at the end of some things, but screening tests to rule out diseases. Not necessarily true at the end, but sometime in the middle of the process, someone coming to you say, Pastor or Elder, please would you pray for me? I need some prayer. I'm having a test. This is a healthcare intervention. That means something is going on. Then you ask the question, what's going on? How are you feeling today? And as we come to end of life care is significant because it is about the total care of a person with an advanced incurable illness and just does not equate with dying. The end of life care phase may last for weeks, months, or even years. End of life care is defined as care that helps those with advanced progressive, incurable, or an incurable illness to live as well as possible until they die. The goal of the end of life care is built on the philosophy of axiology, that is to say, what is of value. End of life care seeks to assist patients, families, and caregivers to make meaning of their life near death. End of life care addresses the brokenness of people and seeks to reconcile life's choices prior to death. Good questions to ask during the end of life care scenarios that you may face. What do you need to do before you die? This can mean writing letters, having conversations, or making funeral plans. Who do you need to forgive? What will you miss most? And finally, how would you like to be remembered? Now, I would suggest that based on many people's thoughts of the imminent second coming of Jesus Christ, many people are so concerned about going to heaven that they are not fulfilling some earthly needs. I would suggest that this is not a time for doctrinal inquiry about the person's heaven or hell status. The goal is presence, not religious assurance. Can you, as a minister, through one question, guarantee eternal life? I would suggest letting the patient or church member bring up a conversation about heaven or hell. That way, they are asking, could you help me to understand more about when I may die? I'll never forget one of my favorite deacons who died recently. He said to me, he said, Pastor, I would like for you to explain to me the second coming. That was him asking me and not me bringing it up to him. End of life care, there are two helpful caregiving options, which are hospice and palliative care for loved ones near the end of life. Being knowledgeable and conversant on end of life care measures with parishioners may give parishioners more comfort. Hospice care focuses on caring, not curing, and in most cases, care is provided in the patient's home. Hospice care is also provided in freestanding hospice centers, hospitals, and nursing homes, and other long term care facilities. Hospice services are available to patients of any religion, race, or illness. Hospice care is covered under Medicare, Medicaid, most private insurance plans, HMOs, and other managed care organizations. Palliative care is treatment that enhances comfort and improves the quality of an individual's life during the last phase of life. No specific therapy is excluded from consideration. The expected outcome is relief from distressing symptoms, the easing of pain, and or enhancing the quality of life. The decision to intervene with active palliative care is based on an ability to meet stated goals rather than affect the underlying illness. So, in summary, hospice is comfort care at home or at a skilled care facility for those who are known to have a poor quality of life or have reached their limit of life prolonging medical measures. Palliative care is a treatment plan or agreement with a team that will include measures to prolong or enhance the quality of life in conjunction with a caregiver and medical team. So, as we wrap up, here are a few practical spiritual resources for crisis care. Number one, I would suggest to guide a guide to praying prayers. Now, for many of you, you may think, why would I need to know how to pray? Well, I would suggest that for some, we've been praying prayers that may not always be scratching the itch that the person needs. An easy way to understand what someone wants is to ask the person or the group what they would like to be prayed for. Since the goal is presence, not being God, your goal must be to be present, to present the person's request to God. The goal is not to present your thoughts of their need to God. That is judging. Case in point, if someone has cancer, they may be asking for you to pray that they would die easy. And because of your love, because of your concern, because of your hope for them to live, you may say, Lord, I can't pray that kind of prayer. But that's what the person prayed for. The other side of it is that someone may ask for you to pray for them, that they would be able to have a test that would reveal certain things. You've got to pray for the test results, not for the test to be negative. The goal is to present your thoughts and not their thoughts. Presenting your own thoughts is judging based on what you think they need. Here are a few effective ways to respond to a death at the hospice or hospital facility. Number one, relax. Your job is to minister to the living. Pray silently, asking what God would have you to do in the room, and also ask God, where are you working so I can join you? Listen and entertain stories about the dead. Don't hide your emotions. Too often, pastors and ministers are seen as unemotional people based on the fact that they are not concerned. But if Jesus cried, I guess we can too. The goal is presence, not superiority. Family may need assistance in selecting a funeral home. The nurse is your best friend. They are there to assist you. This is not a time for a doctrinal study on the state of the dead. Following a loss, there are always surviving members of churches, of your units, of your medical staff, or even your conference team that still need comfort. There are also people in the community who are affected by the loss of your loved one who still need comfort as well. Follow up methods include annual remembrance services, calls, texts, visits to both members and non members, and grief support groups. Also, having annual times of celebration and also grief support groups that meet on a regular basis, not just for people, but also for people in the community. There are some significant ways to honor loss as we round the bend to our final few moments together. Recognize widows and widowers during holidays, or also children of parents who have died throughout the year. Valentine's Day, Memorial Day, and Christmas are just a few holidays that may assist others in knowing that they are still cared for by those they work with, work for, or are members of a communal congregation. Plant trees at church in honor of those who have died. Establish endowments in honor of the person, either an annual musical endowment, educational endowments at a church school, or and also scholarships that would help to benefit those going to both Adventist and non-Adventist colleges. Name a portion of the church building after a person, fellowship hall, or lobby. Steve Maraboli says it like this: I don't want my life to be defined by what is etched on a tombstone. I want it to be defined by what is etched in the lives and hearts of those I've touched. I would challenge you, my brothers and sisters, who are fellow laborers in the gospel ministry, and those who are concerned about the needs of others, that there are many stories that you have heard and some that you may have missed. And I want to encourage you to go and look for the story, but minister effectively throughout the story. Thank you for watching and participating in this webinar today. Please fill out the post-test survey in the link that was emailed to you. Thank you for filling out your informed consent form. And if you have not filled out your informed consent form, please email me at the link that was emailed to you, and I will make sure that that is available. Finally, thank you for your time and participation. I really appreciate your investment in me, and thank you for taking time out of your busy schedule to watch, listen, and participate. Most of all, I hope that your ministry was impacted in a positive way as a result of our encounter together. Remember to carve your name on hearts, not on tombstones. A legacy is etched into the minds of others and the stories that they share about you. God bless you. Thank you so much for participating today. I hope that you have a wonderful experience. God bless you. Bye-bye.